Hi guys, we're back with sessions 18. And in this one, we're going to focus on the most lethal rhythms: heart blocks, ventricular tachycardia, ventricular fibrillation, and asystole. These are the most lethal rhythms, of course. So let's just take a look at what might happen to patients in this situation. Now we're going to talk right now about heart blocks. There are two types of heart blocks, second-degree heart blocks. You have type 1 and type 2. In type 1, which is often called Winky-Bach or Mobitz 1, what we're going to find is, well, now let's first take a look at what's normal so we can see what's abnormal. Here we have a patient, P wave, QRS, T, which is considered normal. Let's take a look at this one. We have the P, the QRS, and the T. P, QRS, T. And then we have a P, and what follows is a PR interval that lengthens. It's a lot longer than the normal one that you would have, which is usually 0.12 to 0.20 seconds. Then the QRS appears, and then the T, and then the P, and then the QR interval lengthens to the point where a QRS is just completely dropped, and then the cycle starts up again. PQRST, then you have the lengthening of the PR interval, and then you have a QRS being completely dropped, and it usually continues in that pattern. Well, these patients may or may not require treatment. They may complain of dizziness and lightheadedness, but you just watch them. According to the guidelines of American Heart, you monitor that patient vital signs, neurological status to see what is going on, because they may not require any special treatment until it may be transient. But in the case of second-degree AV block, it is hardly likely that this is so. And what you see in these patients, which is called Mobitz 2 second-degree AV block type 2, yes, you get the P, the QRS, and the T, but then take a look here. There is a P wave, no QRS follows. Another P, no QRS follows, and then the third P follows a QRS. So what you're seeing here is a patient who is not having consistent blood flow through the circulation. So these patients may very readily complain of lightheadedness and complain of chest pain. They'll require oxygen, a history and physical, and usually what they do with these patients, if it's really bad, they give them what is called transcutaneous pacing, which is only a very temporary method of pacing. An electrode is applied to the chest wall and one is applied to the back, and the doctor usually orders all this, and they are paced. It's rather uncomfortable for these patients, that beating feeling. So usually what happens, the doctor will order a little sedation to make it more comfortable for them. And usually temporary pacing is only done as a temporary measure. It's not TCP, as it's called, transcutaneous pacing. It's not a permanent thing. It's only done for a short length of time. Next, we're going to talk about a temporary pacemaker. And a temporary pacemaker is only, you probably, if you work in the intensive care, will see the doctor put one in. It's done just until a permanent pacemaker can be put into that patient. A temporary pacemaker, when a permanent pacemaker is inserted, you're going to see it goes into the heart. Of course, wires are inserted, and you have what is called a pulse generator. Here you have that little, it usually looks a little circle under the skin of that patient. You can actually feel it there in the chest. And usually what you would see on the EKG is a pacemaker spike. Now, there are pacers that pace the atria, some pace the ventricle, so you may have some that has one spike or two spikes. It just varies. Then we have third-degree AV block, and what is unique to third-degree AV block is you have the atria and the ventricle working independently of each other, so there's no unity. You might find a P wave coming in the normal place in front of the QRS, or it might come after the QRS. There might be a P wave that does not follow with no QRS following. Here's a QRS, there's a P here, there's a P. There is no QRS here following the P, a P, QRS, a P wave. If you're not certain, one of the things you can do is get a piece of paper, put a mark on next to where you think there is a P, and then another mark next to it where you think there is another P, and then move it along the EKG strip to see if those P's are coming up all over the place. And then We must understand that this is done as an emergency when medications are given like atropine and dopamine and epinephrine. So it's usually given IV because absorption is very quick that way. Because all of this is orchestrated by the doctor. You don't just give these medications because they're there. You give them because you've informed the doctor, you've assessed your patient prior to that, you've told the doctor what's going on, and he's guided you along doing all of this. Then let's talk about ventricular tachycardia. Now, what's unique to ventricular tachycardia? It may or may not have a pulse. Ventricular tachycardia, if there is no pulse, is treated identical to ventricular fibrillation. Here we see what it looks like here. It looks like a V, just a V wave. All you see is a V wave. There is no P, there is no QRS. These patients might complain of shortness of breath and chest pain, and of course if there is no pulse, you might not even have a patient who's responding. So it just depends on your situation. Sometimes these patients can be cardioverted, but if they're not responding, then they do exactly what they do for ventricular fibrillation. They're defibrillated. Medications such as amiodarone, and lidocaine are used in the treatment. Now with asystole, you get a P or QRS. Sometimes you do, sometimes you don't. You might just look on the monitor when it alarms and you see nothing but a straight line. You still have a responsibility to go and assess that patient. Check the leads. Make sure the leads are not disconnected from that patient. Check the patient. Is that patient responding? Make sure that it's not just that the leads are disconnected. Is there a pulse? Is the patient breathing? Is there a blood pressure, so that you can be certain that you have the right, you're making an attempt at the right diagnosis. Now we're going to talk about ventricular fibrillation. Ventricular fibrillation, you're not going to see a P and a QRS. Compare this P and QRS to what you have here. Nothing but a coarse, wavy line. Because in ventricular fibrillation, there is no pulse, no heart contractions. And actually what you will get is an unresponsive patient. You need to act quickly because it doesn't take very long. The patient is in cardiopulmonary arrest. What usually happens to these patients, you call a code, and when everybody arrives, these patients, the doctor will probably have these patients, if it is genuinely VFib, defibrillated. Here we can see that this patient was defibrillated and was fortunate enough to come back. We can see that he's got an endotracheal tube supporting his breathing. He has a ventilator also. His vital signs are back to normal, good oxygen saturation, but people had to act fast to get him there. Now, what would cause ventricular fibrillation? Coronary artery disease, myocardial infarction, and then the treatment, CPR, shock, like I said, defibrillation, drugs such as amiodarone, vasopressin are used, magnesium, epinephrine. And to learn more, go to dearnurses.com. There is plenty to learn there at dearnurses.com. And of course, stay posted for more clinical issues. Hope you've learned a lot from this one.